So good morning. It's always a pleasure to be here. Thank you very much for the kind invitation. My name is Philipp Heuberer from Vienna, Austria, and it's a pleasure for me to talk with you about biological augmentation in rotator cuff repair. So how do we go on? Yeah. The question is, why do we need biological augmentation for rotator cuff repairs? As we already heard, retear rates are up as high as 20 to 80% in the literature. It depends on the technique used. I think we're now at about 20 to 40%. And as Rohit Gupta also mentioned, that intact tendons provide a better outcome, and studies show, in fact, that on the long run, intact rotator cuff repairs yield a better clinical outcome, especially strength-wise. And we know that the bigger the tear is, the more likely are prone to a re-tear. But why do repairs fail? Repairs fail because the physiological tendon-bone interface is not recreated, which consists of tendon, unmineralized, mineralized fiber, cartilage, and bone. So if we repair a tendon to bone, the tendon heals with scar tissue formation, where we know that this has diminished biological and biomechanical properties, and these are prone to failure. So one of the first ones who studied this in deep, and as a cornerstone study, how we can overcome this scar tissue formation, was Scott Rotator with his study on augmentation of tendon to bone healing with osteoinductive bone protein extract. And he augmented infraspinatus repair of sheep with these BMPs. And he saw already after 6 to 12 weeks on the MRI that there was a much higher bone and tissue volume, that there was a more robust fiber cartilage shown, and oriented fibers. And even in the biomechanical testing, the therapy group was much stronger than the repair group. And this was when all the PRP hype started. And but the problem with platelet-rich concentrates is that PRP is not PRP. There are different preparations, different manufacturers. We don't really know what's in there and how long it's going to be released. And in fact, also meta-analysis, systematic reviews, and also a very good designed recent study showed that unfortunately there's no improvement in clinical outcome or re-tear rates using only PRP. But that doesn't mean that the idea is wrong. Maybe our concept is wrong. And that's where demineralized bone metrics comes into play. What is it? It's already known since 1965, developed by Urst. That's demineralized bone metrics works that with the demineralization process, the osteoinductivity of the bone and of the collagen-bound growth factors are released, and so the osteoinductivity is increased. And the theoretical advantage of DBM versus isolated growth factors is that there is a biological matrix. It's full of growth factors and cytokines in physiological amounts and concentrations. The growth factors are released over time, and there were very promising animal models. But if we use DBM, then we have to watch out that they are osteoinductive and not only osteoconductive, and so therefore they have to be human. And we have to watch out what product we use, because preparation, sterilization may decrease or kill osteoinductivity, and so do carrier materials. I did a study myself using DBM in the sheep model, and already after 4 weeks we could observe well-organized collagen fibers and more or less physiologic-like enthesis. The DBM was fully replaced by trabecular bone, and we drilled holes and put the DBM particles in. And the very interesting thing was that in the histological sections, we could observe that the more we were away from the DBM, the more disorganized the enthesis got. So I was looking for a long time to find the right DBM product, and finally I found it. It is so-called FlexiGRAFT, provided by LifeNet Health, distributed by Arthrex. Has the advantage that it comes in great sizes for rotator cuff repair augmentation. It naturally absorbs PRP or BMC. It's 100% demineralized, sterile. You can store it at room temperature. You get it off the shelf. And the most important thing, it's tested on osteoinductivity. So every lot is tested in an intramuscular nude bioassay, and the osteoinductivity is proven. So what do? A standard rotator cuff repair. I debride the foot and prepare the tendon. then put my medial anchors, repair my medial row. Then what I do again is, as we already heard, footprint drilling, nanofracturing, or whatever it's called, multiple channeling. And then I take the FlexiGRAFT and put it underneath the tendon and close it in a suture bridge-like fashion. And this is already after 3 months post-op, an example of a repair. And what we can see here already a different signal. Here you can see the FlexiGRAFT in the circle, and it's black. And normally what we know is from tissue healing that we see liquid in it, and it looks different. Another very appealing option for the augmentation is the augmentation with mesenchymal stem cells. What they are pluripotent cells which can specialize into any other cell depending on the environment and the BMPs that are there. The problem is that there are very low numbers, and we do not yet know the optimal cell number we need for healing. There are very few studies out there, only 2. One by Alero Gomez. They used low numbers, only 14 patients, had no control group. They didn't observe any retear, but a very promising study by Philipp Heuberer in France, who had a 10-year follow-up of 56 patients compared to a control group. And he could observe a reduction of the retear rate of more than 50% at 10-year follow-up. And in the first 6 months, he didn't have any retear in the augmentation group. So thanks God, there are very great devices at the moment. So I use the Arthrex Angel system. It's a point-of-care centrifuge. You can use it in the OR. And what I do, I take my bone marrow ovals from the iliac crest, because this is known to have the highest yields of mesenchymal stem cells. You have to use small syringes, aspirate only small volumes from different spots. And with the Arthrex Angel system, you get the most out of your aspirate. And one step ahead is again to load the MSCs onto the FlexiGRAFT, and this is what it looks like. What we need is, it needs to be a stable construct. We need to have viable cells, and they should be released over time. So the problem with all the other techniques where you inject the substances only, you put it on a sponge or whatever, they don't work, because as soon as you put it arthroscopically into the shoulder, it gets washed out. And this is the challenge, to create a way where we can guarantee a stable construct. And I tried it with many different products, and unfortunately there's not a product off the shelf now on the market. We need to use custom-made fibrin glue to stick the BMC onto the FlexiGRAFT. Why custom-made? Because in the off-the-shelf products, the fibrogen the percentage is too high, so that it will kill the cells, and there's nothing left. But with this glue, you can handle it. The cells are viable. We tested it, and it looks very stable after, even in arthroscopy, where you can see the cells stick there. It's red even with a 50-70 millimeter flow. But to start with, as we already heard, the crimson duvet technique is a very promising technique where you drill holes into the footprint. The important thing is that you go deeper than the normal microfracture, because the cell cytokines, the stem cells you want, they are below the subchondral bone level. And in fact, there are clinical studies that show the benefit of this technique. There are 2 level 3 studies that show a significant reduction in the retear rate when you use footprint drilling or multiple channeling, as they call it. There's one level study that could not observe any difference, and another study of Giuseppe Milano, who could see improved healing rates in large tears. The question is, why do we have these controversial results? That's maybe in the fact that, as Philipp Heuberer could show, that if we have in a chronic situation the mesenchymal stem cells, it's much lower than in the acute situation. So the longer the defect stands, the cells diminish. So in conclusion, we can say that despite the technical advances, An improvement of healing biology is the goal. The structural intact tendons yield a better outcome and better options for the future. The aim of every repair is to get a stable construct, and biological augmentation is the recreation of the physiological tendon to bone interface. But we still lack the understanding of how we should do it, what we need, and there are some difficulties to face. The advantage is we don't have nearly any potential complications, and I think that DBM and MSCs have the real potential to significantly improve rotator cuff healing. Thank you very much.